Let me just take a check. 2 hours is often a convenient time to take a short break. On the other hand, I'm not sure how much longer the rest of the business will take us. Are you willing to bear with me and to press through for the rest of the agenda? Good, right. I'll take that as a yes while we move on. We've got the next item on the agenda, item 9, is the NHS performance report. Barbara, thank you very much for this report. And can I commend the succinctness and the focus of the report and invite you to comment on it.
Thank you, Chairman, and in the interest of time, I certainly won't go through the whole report. I'd like to highlight a couple of issues in the report and expand on them for the board, and I'd also like to mention one other issue alongside that. I'd like to highlight the outcome of the planning and contracting round, where NHS England teams have been supporting our CCGs to make sure that the total amount of activity commissioned for our patients was adequate. It's absolutely vital that our provider services can make the right plans in order to put services in place for patients. And as a result of a lot of hard work on everybody's part, we are now offering contracts where there are 6.8 million extra elective spells, which is an increase of 2.7% over the previous year, and an increase of 5.6 million non-elective spells, which is an increase of 2.3%. So those are being offered in contracts to providers, and for the most part, all the capacity that is required has been secured. This isn't to say that it isn't our ambition to reduce some of this activity, which we all believe is unnecessary, and where it would be better for patients to have more comprehensive services at home, in the community, in the primary care setting, earlier in the course of the disease, in order to reduce the need for that admission, particularly, I think, with non-elective admissions. So running alongside that, every area has got, through the BCF, an ambition to reduce particularly the elective activity through a range of interventions across health and social care, and hopefully those ambitions will see that this activity is not all found to be necessary as we go through the year. Where places haven't been able to secure the activity from providers, where there are capacity problems, we continue to seek that capacity. It's very small numbers, small number of places, small number of specialties, working with other NHS and independent sector providers to put that in place. The next steps really are looking at the contingency, because whilst we would be optimistic that every bit of activity would be delivered across the country, we know that certain things have an impact on providers' ability to deliver all the interventions necessary. So we've got in place a comprehensive PMO across England, which looks at, is identifying all the available additional capacity, both within the NHS and with the independent sector, which we could draw on in any instance where we see that the commissioned activity is not being delivered. Plainly, if we see that the commissioned activity is being outstripped and our CCGs haven't commissioned sufficient activity, then through our local offices we will need to go back around the loop with them and make sure that very quickly in the year they commission the extra activity so that providers can put things in place. The second area I'd like to highlight is cancer, particularly on the back of the last conversations that we've had. I think important to remind everyone that 9 out of 10 of the cancer standards are met, but we are falling behind in the 62-day cancer standard. This is for good reasons, not for bad reasons. It isn't that the NHS isn't delivering lots of activity and lots of care for patients. It's because of some of the interventions, because of awareness and patients coming forward earlier and a lot of the campaigns we've had, more and more patients are presenting who might have cancer. So there's more to deal with, and what's happened is we are treating more patients, but not enough. So we've got a number of immediate steps in place and some longer-term steps in place. Many of the longer-term ones, of course, will be aligned with what goes on in the cancer plan. But just to let the board be aware that working very, very closely with TDA and Monitor, We have a plan to address the failings in the cancer standards, a comprehensive plan across a range of issues. The most important one probably being to put more endoscopy capacity into the system, because there's really good evidence that this is where one of the biggest blocks is. So again, we are assessing the total amount of endoscopy capacity that is available across the country, because often there are mobile units who can deliver this service, so it isn't about having to persuade patients to travel long distances or away from providers. So our short-term focus is on a number of flow issues within trusts. As I say, we're working closely with Monitor and TDA on this, and on making sure that we have the right endoscopy capacity where necessary. But in the medium term, we will be working with our tripartite partners to make sure that the capacity planning for the increase which we expect to see, we've already seen an increase, we expect it to become greater. So for now, our heavy focus immediately is on those areas where there obviously isn't enough capacity and they're not delivering the standard. But in the more medium term, we're going to be working with every area across England to make sure that they've got the right capacity plans in place to see us through future years, not just for this year. So those are my two things to highlight within the report. I would just like to mention to the board, if I can, just give an update on exercise Strong Tower, part of our emergency planning exercise, which for obvious reasons couldn't be in the written report at the time it came out. The board will be aware of NHS England's role in the event of a serious emergency. The role changes completely to one where we have complete responsibility for ensuring that the whole of the NHS acts in concert and acts appropriately. We do a huge number of exercises in the emergency planning team with the NHS and within NHS England, both at local, regional and national level, to make sure we're prepared. But it's rare that there is such a big exercise as Strong Tower, which was a Tier 1 exercise initiated by the Home Office, which was about, it's part of the terrorist response. So the exercise was about a marauding firearms attack and terrorist siege. We took part, obviously, to make sure that there were two things in place. Firstly, that we as NHS England could play our part as part of a very complex system when something like this happens, but also that we could make sure that the response in the NHS was absolutely right. It was a 2-day exercise, as I said, Tier 1 exercise with COBRA and ministerial involvement in it as well. The main things for us were standing up the full incident response team nationally and standing up the full incident response team in London, because plainly when these kind of things happen, there is an assumption that the height of the problem will be in London. So our London team have a very significant role to play in this. The early hot debrief from Strong Tower was that the NHS, we stood up very well, and that for the most part everything was in good place. What I would like to do perhaps is to bring back to the board for the next meeting a full written report when we've had the cold debrief and work out all the lessons that we've learned and what changes we will be making on the basis of this. But I just can assure the board that on the basis of this, there was nothing major from the hot debrief that we would say needs to be done immediately, and our processes appear to stand up well.
Thank you very much, Barbara, for that report and for the Strong Tower report. Questions to Barbara? Victor.
It is a very clear report, thank you. On the ambulance service, I'm just aware of, I'm curious about the ambulatory response to mental health crisis, which is something which I've been concerned about for some time. You mentioned the paramedic training, and I just wondered whether the mental health response has been included in that training, and similarly the ambulatory response to a mental health crisis, which has often been lacking. So that what happens is that someone in crisis, particularly like me, is more likely to get a police response, which is frankly risky, than an ambulatory one. I just wondered whether that was part of your thinking, or is going to be.
Well, two answers to that. There is certainly work that goes on with the ambulance services, which NHS England teams are involved in, to improve the response in mental health crisis and patients with mental health issues, to make sure that they're taken to the right place, that there's a good ambulance response and that they get the appropriate treatment. And also we're doing a lot of work with A&E departments to try and ensure that there's good access to mental health professionals with A&E departments once they get there. I don't know, Victor, in answer to the kind of training of staff. This was particularly about there is a national shortage of paramedics, and a couple of our ambulance services have had to seek paramedics coming in from abroad. London Ambulance Service, for example, has got already got about 150 paramedics in from Australia, and we'll be recruiting more. But I will happily take back, we're working with Health Education England to firstly to increase the recruitment of paramedics from the UK in the future, but I will take that back and ask about the training of paramedics on mental health issues.
Thank you.
Right, well, thank you very much, Barbara, for the report.